For the next session, I'll request chairpersons. This is a very important session on congenital heart disease. So I'll request all the speakers are there. We'll request Dr. V.K. Thakur sir. Dr. Prabhat, are you here? Dr. Prabhat? Dr.
Yes,
Prabhat.
sir. I'm here, sir.
Okay. So I request you to take over from here, and all the speakers are there. You can start the session. Dr. Prabhat.
Thank you very much, Nishant, sir. We'll start the topic on congenital heart defect. And our first topic will be the when to intervene in the left to right shunt by our esteemed speaker, Dr. Parang Bhalgat from Mumbai. Now over to our chairperson, Dr. Anil Kumar Thakur and Dr. B.K. Thakur for brief introduction of the speaker and moving ahead of the topic.
I think we can request Dr. Parag to please start the session because we are already behind a bit late. So let's hear his views.
Okay, okay, I'm Dr. Parag here. Am I audible and clear?
Yeah.
Yes. Audible.
Okay. I have first thank Abhinav Bhagat and CSI Bihar Scientific Committee team and CSI for giving me this opportunity to discuss this important topic with all the delegates. So my topic, I'm going to discuss when to intervene in left to right shunt. The most important thing I want to stress is what are the risk benefit ratio and when we should not intervene and when we should intervene. As we all know, Hippocratic Oath, which talks about first do no harm, but sometimes our decisions of not doing surgery harm the patients. We think that we should postpone the congenital heart surgery at a later date when baby grows old. That is the biggest harm that we are doing. So I'll just take out some important points and discuss them. So I will discuss why do left to right shunt require closure, when we do it early is too early or when it's late too late, and how it is all to do with hemodynamics. How to close defect, this is not my point of discussion today. This is all anatomical consideration. So we will discuss mainly hemodynamics and related things. So talking about risk and benefit ratios, there is benefit which clearly outweighs risk, but it is when we have to select the patient. Sometimes we see a patient where doing surgery or doing intervention may not benefit. This is particularly relevant in cases of small shunts, like small ASD, small PDA. And sometimes we see a patient late in natural history where doing surgery can be very high risk and benefit may be questionable. So it is cases of irreversible pulmonary hypertension. So let's see how we sit here, how we categorize patients. So what are the outcomes? What are the adverse outcome of left to right shunt? Why we want to intervene? First and foremost is patient is symptomatic. All these patients are at risk of development of severe pulmonary hypertension. They are at risk of having sudden death due to severe pulmonary hypertension. Peak tricuspid shunt have atrial arrhythmias and embolic risk. And all these patients have got a truncated life expectancy. So in the case of Eisenmenger's PDA or VSD, life expectancy is up to second or third decade, not more than that. ASD is a little longer, but it's quite less, and the life is quite debilitating. So I'm just putting forward two cases to provoke your thoughts. This one is a 70-year-old gentleman, hypertension on regular medication, no diabetes, class 2 symptoms in 7 years. A fixed speed S2, soft ejection systolic murmur, saturation is 95, constant exertion. Echo suggestive of large ASD. Okay, and cath data suggestive of pulmonary vascular resistance of 5.4 Wood unit and QPQS 2.3 as to 1. PA pressure is little more than third systemic. And I'll contrast this with another patient First one was elderly gentleman. Second is a 21-year female. Last 3 symptoms since 1 year. Fixed with S2 with soft ESM. Saturation is 91, decreases to 87. Again, the large ASD with severe pulmonary hypertension. QPQ is just 1.3 as to 1. PVR has increased to 13 Woods units. PA pressure is more than systemic. These two things I have taken from my patient substrate set. So first case, we will discuss whether it is beneficial. In second case, whether it is beneficial to go ahead and close this. What are the level of evidences and what are the scientific evidence? We frequently use X-ray, whether there is a what is vascularity, what are endon, cardiomegaly, all these parameters. We also use ECG, whether to operate or not. This is ECG, first case being operable, second being having QR pattern with RVH with strain. In second ECG, suggest of non-operable. But all these things we need to sort it out. Now just look at this echo loops. This is a young female with ASD and fair size LV and dilated RA-RV. We can clearly demonstrate left to right shunt. As against this, see this patient with who is little late presentation, moderate TR, PA pressure close to 150 and interventricular septum going to the left during systole, going into the LV. LV is just going crescent shape. PA is 3 times related to aorta. Now this suggests that she has developed severe pulmonary hypertension and she is late in the natural history of disease. Now we are going to come across whether the patient has got developed some cyanosis. Now when we talk about cyanosis, we always first think of severe pulmonary hypertension. So in that cases, we need to consult expert. But there are some cases of cyanosis which are irrespective of, not related to pulmonary hypertension. It may be just abnormal tricuspid jet directed to ASD, abnormal systemic pulmonary venous drainage, like left or right SVC draining into LA. These are known entity. I have come across all these malformations, pulmonary AVMs, unroofed coronary sinus, common atrium, especially large phymum ASD. Some cases of RV cardiomyopathy and Epstein anomaly can have desaturation with ASD, which is due to the inability of RV to take extra volume. So coming to ASD and how we should go ahead, this is from ACC AHA 2018 guidelines. If there is a clear-cut left-right shunt and PA pressure is less than 50% systemic with right heart enlargement, QPQ is 1.5 to 1, we should go ahead with the surgery. Even asymptomatic patient, it is a class 2 indication. If PA pressure is more than 50% and PVR to SVR is more than 1/3, then we need to evaluate more. Evidence goes to class 2B. Now, if it is documented right to left shunt with very high PA pressure more than 2/3 and PVR SVR more than 2/3, then it comes to a contraindication. Closing this ASD will make them a primary pulmonary hypertension. So ASD pulmonary hypertension has a natural history of 10 years as against primary pulmonary hypertension only has a natural history of only 2 to 3 years. So we are making it a worse disease. So we have to distinguish all these 3 categories. Just making a tabulation. These values are applicable to all pre-tricuspid shunts, which may be anomalous pulmonary venous drainage, sinus venosus ASD, common atrium. With some variations, we can generally apply. Class 1 indication remains symptomatic patient with QPQS 1.5 to 1 with PVR less than 1/3. And as we PVR and PA pressure increases, class 2B, and if it is very high, class C, contraindicated. Coming to role of ASD closure, the first patient we discussed. In presence of suitable hemodynamics, there is a significant improvement in symptom class. So there is a definite improvement in effort class. Patient feels symptomatically better. Effort tolerance improves. There is definite evidence of pulmonary hypertension being regressed. These benefit present even at 12 months follow-up. The only question we do not know whether this increased the longevity of life. I'll discuss the little next slide. Now, this is a 1990 landmark paper from NEGM. We had the followed up ASD closure patient for more than 3 decades. The median follow-up was more than 25 years. So all the patients who were less than 24 years of age, when they were compared with age-matched control population or symptomatic, the outcome was equal. There was no loss of life expectancy. But as age increases, there is a definite drop from 91 to 84 and 59 to 40% in life expectancy at 27 years. Now, combining this with pulmonary hypertension, if we operate a 24-year-old with PA pressure less than 40 as against the PA pressure more than 40, there is a definite drop of 9% in life expectancy. There is a 95, 98, and there is 98, 86. So as PA pressure increases, life expectancy goes down. This is more marked in about 24 years of also. As we see, even at more than 24, less than 40 years, there is no change in life expectancy. So most important factor that determine the outcome of ASD closure is when we operate and what is the PA pressure. ASD closure less than 24 with PA pressure less than 40, the patient have a normal life expectancy. Any of these, especially PA pressure goes more than 40, then we are in trouble. Now this is come to the adult. Now coming to the pediatric population. If we come across ASD at age of say 9 years or so, or maybe say a innocent normal baby has come to you in OPD with a 6 months age, otherwise asymptomatic, little less weight as compared to the peers or standard. Now we are diagnosed with as a ASD. If defect is less than 8 millimeter, they generally close by 3 years of age. So wait and watch. If defect is more than 11 millimeter, it's unlikely to close. So current ACC guidelines recommend that wait for 3 years of age for ASD closure. If baby is asymptomatic, if baby is symptomatic, then we have to consider closure little earlier. So it may be at 1.5 year, 1 year, depending upon the symptom of the patient. Now coming to post-tricuspid shunt, these include VSD, PDA, AP window, then we can talk about coronary cameral fistula, or few more things, or RSOB. I'll discuss them individually. So these defects with large, when these defects are large, symptoms are there since infancy, within first couple of months. So they present with poor weight gain, suck cycle, and low respiratory tract infection. Conventionally, or what, I don't want to go into details, but initially we used to think that baby should wait till 10 kgs of weight or 2 years. Many times somebody advised them no wait, the hole will close on its own. And this is the worst advice that we give to these kids, because time to Assen mingerization for this set of patient is quite fast. Large VSD will Assen mingerize 2 years, AP window less than 1 year, and PDA, large PDA, we can have Assen mingerize at even 1 year, 8 months also. We have come across occasional cases where you are struggling with the patient even at 1 year, that there is a definite right to left shunt in PDA and test balloon occlusion of PDA, there is a PA pressure going above the aortic pressure. So the typical cases, no, there is no significant gradient at this VSDs that I have shown. This is a perimembranous VSD, or this in subcostal view. Even in some cases, you say no, there is a bidirectional shunt. But as these patients are at less than 1 year with, they have got a definite LAVO, LVVO, we should not have second thought. We should go ahead with surgery immediately. So coming to the decision making, more or less same chart is there. If there is a definite left to right shunt, even in adult of 8 millimeter symptomatic with definite left to right shunt with some gradient, with, and you are little doubt, then go ahead with QPQS estimation. We may do a cardiac cath, estimate PVR, pulmonary vascular resistance. If everything is okay, go ahead with surgery. Even perimembranous VSD or subpulmonic VSD with cuspal prolapse and mild aortic regurgitation makes an indication for a surgical closure, because if we leave them alone, the AR will progress and maybe 5 or 7 years down the line, they will require aortic valve replacement, which is a major disease, than doing just VSD closure and leaving them with a mild AR. Mild AR has got a very good natural history. So we should doing, what to say, that is the way we should target this population. Occasionally, we do come across a symptomatic 1 year, 2 year kid with mild cuspal prolapse and AR in subpulmonic regurgitation. We do not give the importance to the AR. Maybe after 5 years down the line, he has developed moderate plus AR. At that point in time, complete correction of AR is not possible, even if we close the VSD. So that is important. Again, there is indication for closure of VSD if there is infective endocarditis with no surgical contraindication. As PVR and PA pressure increases, we need to evaluate patient more with QPQS, cath, and in definite right to left shunt with Eisenmenger physiology. We have to should not close the VSD, give them pulmonary hypertension therapy. So these are the ACC AHA guidelines, more or less as that of ASD. Again, it gives a couple of extra points. Is cuspal prolapse with mild AR class 2A and infective endocarditis is the class 2B indication. As I already mentioned, a symptomatic infant for VSD, PDA, even for AP window, early surgery correction is very important for good long-term outcome. If we postpone the surgery, there is a problem. Most centers across the India do VSD closure at less than 6 months of age with minimal mortality. At the center where I work, we do VSD closure in a symptomatic patient in 3, 4 months, 5 months with a very short ICU stay with a negligible mortality. So we should not threaten patient. We should say it's a low risk surgery, but it is important. We should go ahead and do it. Do not postpone surgical correction to a later date because it increases the risk of residual pulmonary hypertension after surgical correction. Maybe he is always at risk of death due to respiratory tract infection, and he will have failure to thrive. So timely intervention is most important thing. Coming to partial anomalous pulmonary venous connections, if only 1 or 2 veins are draining into RA, it is insignificant shunt, conserved. They generally do not need any treatment. Sometimes these patients have got respiratory symptom, but they are generally due to allergy. We have to quantify them because sometimes we attribute it to the PA-PVC, and even after surgery, the symptom persists. So that is not a justice. If there are 3 or more veins draining abnormally, it's a significant shunt. Go ahead and correct it. PA-PVC with ASD, especially as seen with sinus venosus ASD. Even sinus venosus ASD is small. There are generally 1 or more veins draining abnormally, and then have a significant shunt. Better go ahead and treat it, correct it. Coming to rare defect, coming to coronary cameral fistula, the shunt may not be significant, but the shunt per se lead to significant dilatation of coronaries with age. Now, at later age, if we close those shunt, then coronary may not regress in size, and they are at risk of having thrombosis or coronary event. So early closure may prevent sequelae. Coming to ruptured sinus of Valsalva, now it's a very acute presentation. It's poorly tolerated by the patients. So important thing is to diagnose it promptly and go ahead and close it. Coming to little tricky issues, sometimes we come across a moderate VSD and baby is failure to thrive, and we screen more, we see a moderate PDA also, or moderate ASD, moderate VSD. So in this case, if baby is symptomatic, go ahead and correct it. Do not wait, because 2 moderate shunt behave like more than a big
please
shunt.
make it faster.
Yeah, I'm about to finish. Okay, and they've symptomatic early. So important thing is when you diagnose, close a lesion, close it unless contraindicated. Okay, and while decision making, use all possible clues. Okay, thank you. Done.
Thank you, Dr. Parag.
Yeah.
Over to Dr. V.K. Thakur, sir. Dr. V.K. Thakur, sir.
I think we are now very clear in our minds, and if any questions from any audience that can be taken. Otherwise, we can proceed with the next because we are running behind schedule.
Right, sir.
If any comment by another other chairpersons that can be taken, we
The
can
second
proceed.
topic is approach in pediatric heart failure, and chairperson is Dr. A.K. Jaiswal. I don't think he is in the group. So should I call our esteemed speaker, Dr. S. Ramakrishnan, sir?
Yes.
Hello.
Yeah, I'm just sharing my screen. Is my screen visible?
Yes, sir.
Yes, sir.
Okay, so I think at the outset, I would like to thank the opportunity given by the seniors. So respected seniors and dear friends from Bihar chapter. I think I'm going to talk about the pediatric heart failure with a 4-year-old boy as the center of it. So there are some different rules because most of you are practicing adult people. So there are some different rules that are set, like children are not small adults. That is rule number 1. And rule number 2 is that, as told my previous speaker, most of the pediatric heart failure is due to surgically correctable lesions, so which needs surgery, and most of these pediatric heart failure can be cured with surgery if it done in time. So the common condition that he has already enumerated made my job easier are not ventricular dysfunction related lesions. Most of them have a preserved ejection fraction, but do produce heart failure because of various reasons, because of over shunting or because of increased pulmonary blood flow and all those things. But in a 4-year-old, what will be the commonest causes? I think a BSD, PDA generally don't produce such heart failure. Generally, they produce heart failure in infancy most of the time. Especially epipindoid, single ventricle, all of them are associated with heart failure in infancy. And by the time the patient reaches 1 or 2 years, generally the patient either dies, or patient develops severe pneumonia, or patient gets operated, or some of them they settle down because there is a phase of PH comes in. I think by the time PH comes in, their increased QP related symptoms and heart failure settle down, giving a false sense of security for the patients, and ultimately they end up developing Eisenmenger syndrome, which is a very common thing in our parts of the country. So the other lesions are extremely uncommon, like a TGA, TA, PVC, and truncus in a 4-year-old. But at 4-year-old is actually the crossing time where we have seen a few rheumatic heart disease also, and a lot of congenital valvular lesions come into the picture. And the AS and PS and coarctation of aorta in India can be found in almost all ages. But the other important things is the patients who have ventricular systolic dysfunction. So they have either primary cardiomyopathy or secondary cardiomyopathy because of various reasons. And some of the things that commonly not in the mind of adult people is one is Alcapa and the tachycardiomyopathy, which is reasonably more common than in adults. And you have now with the advent of pediatric oncology, I think a lot of patients with anthracycline-induced cardiomyopathy we are encountering, and even non-cardiac causes like sepsis are also encountered. But sometimes patients with congenital heart disease also can have LV systolic dysfunction because of the cyanosis, or because of the way the ventricle is formed and the developmental issues with the ventricle, or after surgical corrected also there can be residual or late ventricular dysfunction. So rule number 3, children don't present with the same signs that we are looking for. So the signs like raised JP is extremely difficult to figure out in a child, and peripheral edema and effusions and chest crepitation, most importantly, are not generally a feature of heart failure in children. So chest crepitation generally suggests a possibility of a lower respiratory tract infection. Children commonly present with tachypnea, chest retraction, irritability, lethargy, diaphoresis during feeding, this typical sucrose cycle, and the decreased volume of feeds and poor weight gain and failure to thrive. These are more common features. So NHA we can relegate to Trump, and modified Ross heart classification should be the one that should be used in children, like the 4-year-old kid, class 1 being asymptomatic. Almost the activities have changed, but the pattern remained the same. Generally, the investigations reveal a bit more rather than in adults. For example, this is a different X-rays that can tell you the diagnosis based on the X-ray itself, which is very rare in children. Whereas in very rare in adults, but in children you can find a diagnostic ECGs that can tell you the diagnosis. Somehow echo is the most important investigation in all these children, but the utility of NT-proBNP is not that well established as compared to adult practice, even though there are some papers that suggest that clearly it can be used to distinguish between cardiac and pulmonary involvement in neonates and children. So the level of greater than 300 picogram per ml is known to predict poor outcomes in children with heart failure. So the most important and the most worrisome rule is that whatever we do for managing these children is not evidence-based at all. So the drugs remain the same, but there is absolutely literally no evidence for these agents. So the diuretics are one of the most commonly used, as in adult practice, most commonly used for treatment of heart failure. So the dose is 1 to 4 mg per kg per day in divided doses. So the same adverse events are there. But infant tolerate it much better than adults. Generally hyponatremia, they generally tolerate it, but these things do happen in children. So digitalis, I think in India, it's commonly used, whereas in the Western countries, it is not so commonly used. With the same with adult practice. I think contraindication being myocarditis, and the dose are, I think, well written in most of the textbooks. So what is the impact of this therapy? I said there is no evidence, but overall there is some evidence to suggest that in a smaller group studies, unlike the adult studies of 8,000, 10,000 patients, we have around hundreds, the patient numbers are in hundreds, where the combination of digoxin plus diuretic, AG inhibitor plus digoxin, AC inhibitor plus beta blocker, and no oral maintenance treatment have been compared. And clearly there seems to be a survival advantage with AC inhibitor plus digoxin and AC inhibitor with beta blocker, even though statistical significance is not to be found. So there are multiple small studies that actually looked at the issue of AC inhibitors in DCM in children with DCM. And these are the various studies. I think the key findings remain the same. One interesting development that has happened now is the sacubitril valsartan. The Panorama Heart Failure trial is actually ongoing. It is enrolled. Enrollment has finished. We are in the process of following up. We are also part of the trial. Based on the initial safety analysis, FDA approved as treatment in the heart failure in pediatric patients. Based on the safety analysis, I think this trial, will open up a good window of opportunity for treating in these children with heart failure. I think the drug is, even in our experience, the drug is pretty well tolerated. I think the drug may be possibly better tolerated than in adults, because symptomatic hypotension is not so common in these children compared to adults practice. Coming to beta blocker, which remain the mainstay of treatment in any heart failure therapy, the largest heart failure trial done by Dr. Shady et al. Had 161 patients, and then he had low and high dose carvedilol to placebo to conventional arm. I think the problem was that this trial included a large number of patients who belong to CHT, who belong to DCM, who belong to various other classes. So I think it ended up having non-beneficial trend in having those who are systemic ventricle is not LV. But even though ejection fraction certainly improved, all the three groups, but it improved significantly more in ejection fraction, improved more in carvedilol group. So these are the various other trials that have been done with carvedilol or metoprolol, but they're all very small studies to make a final conclusion. So even a study is published with ivabradine in patients with chronic heart failure in children. But as I told you, the evidence is very limited for most of this therapy. So the advanced therapies are possible in children in today's time, like LVAD is possible, the ICD is possible, even CRT is possible in selected centers, and some of the advanced centers can do it in India also. So these should be considered. And even pediatric heart transplantation has become a reality in India, with a few cases being successfully done. Even our institute has performed a pediatric heart transplantation, and a lot of cases have been done in the south also. So that is also has to be considered. But the most important message, the take-home message of my talk is always look for reversible causes in children with DCM, who present with DCM. So I will tell you some classic case example. This is a 4-year-old presented with class 4. She was diagnosed at DCM on follow-up, and she was on follow-up. The heart rate was 140 regular, and the ejection fraction was 15%. So what is there? Can anybody make out? The previous ECG and the post-procedure ECG. So this actually had a patient had a atrial tachycardia, which required ablation, and after ablation, the patient became a normal ECG, and the ejection fraction improved tremendously. So this is the. So maybe the runs are not playing, so I will move on. So this was a 4-year-old male. Male child with a presented with severe LV dysfunction, and post ablation the LV dysfunction improved significantly. And actually this patient had a subtle form of WPW syndrome, having a right-sided pathway, which was actually ablated, and then he became all right. So even at times pathways can produce ablation, can produce this. So this was a 6-year-old female. I think had all peripheral pulses were weak, but had a heart rate of around 140 with a BP of around 110 in the upper limb and 110/80 in the lower limb. The duration of illness was very acute, 2 weeks duration, and there was the pulses were weak. All the pulses were weak. So an attempt was made to look for coarctation of aorta. There is no coarctation, but then the patient had abdominal aortic narrowing and a typical Takayasu. The BP rose to 130/80 when the patient was stabilized, and this was the typical picture that you can see. So you can see a typical narrowing of Takayasu in our parts of the world. I think this is fairly common. I think after the pre and post balloon angioplasty, there is tremendous improvement. The ejection fraction improved. And some of these children also present with renal artery narrowing. I think a good look has to be there for all pulses, palpating all pulses. And the best way to diagnose coarctation of aorta is palpate the pulse, palpate the lower limb pulse. Especially if you are a clinician in practice, you cannot do it in, especially in COVID time, if you cannot do it in your OPD, the best place to do it is in your echo lab. So when the child is lying comfortably, I think you should always make an effort to palpate the femoral pulse. I think coarctation is easily diagnosed, and renal artery narrowing and the various forms of Takayasu arteritis and aortic thrombosis, all these things should not be missed because they're all treatable causes and the ejection fraction improves immediately. So this is a classical picture where you can see the typical Q waves that are formed, very well formed Q waves in the lead 1 AVL and V5, V6. And this is actually a severe LV dysfunction in a younger child, but you can see classical anomalous left coronary artery from pulmonary artery. So at times it may look like it is coming from aorta, but you have to really carefully see to make sure that there is a flow is identified and the connection is classically made. So these are the various reversible causes that everybody should look for. And one more thing I didn't cover in detail is, because of want of time, is the hypocalcemia, which is fairly common in our parts of the country, especially vitamin D deficiency in children. An attempt has to be made. I think if you do an echo, possibly you will not miss aortic stenosis, pulmonary stenosis, and coarctation of aorta, non-specific aortoitis can be at times missed by echo, but they cannot be missed if you palpate the femoral pulse. And a critical look at the ECG is very, very important in all patients presenting with DCM-like picture. And always remember, look for Q waves, and always when you're doing the echo, always look for the coronaries, whether they are connected normally, whether they are normal or not. And definitely all children presenting with LV systolic dysfunction should have their calcium, thyroid, and vitamin D levels checked. I think these are very important. And then definitely history of doxorubicin, adriamycin will be available. But oftentimes we end up having none of them, and then we end up labeling them as viral myocarditis. Even children can have Takotsubo cardiomyopathy also has been described in children. So to conclude, children are very different and their heart failure is totally different. Unlike adults, heart failure in children is commonly due to structural heart disease and reversible condition. Outcome of heart failure is generally better in children than in adults. And major future direction is to improve treatment is need for well-designed trials with adequate power for support of treatment recommendation. Thank you for patient listening. Thank you.
Thank you, Rama sir, for a wonderful and brief, informative your topic. May I over to Dr. A.K. Jaspal sir? A.K. Jaspal sir? I think he is not there. Thank you, sir. Thank you, Rama sir. We'll move on to the next topic. Hello.
Hello.
Thank you. Thanks a lot.
Okay, thank you, sir. We'll move on to the next topic by Dr. S. Radhakrishnan, sir, for the topic of transcatheter pulmonary valve replacement and its current status in India and abroad.
Thank you. I want to thank the organizers of the Bihar CSI for having allowed me to give this talk. It's very nice to see these familiar faces. It's been a long time since we have met with each other. I'll quickly go on to my topic, the current status of transcatheter pulmonary valve replacement. You must have all heard, and I've been very excited with the transcatheter aortic valve replacement, which is being practiced almost now all over the country in various parts of a state. I'm not able to control the slide, please. Okay. So transcatheter pulmonary valve implant is now a part of a standard practice in many centers across Europe. And it's now been 15 years since the first Melody valve was implanted in the pulmonary position. It is still in its nascent stage in India with only a few selected centers practicing this. We report our initial experience with this procedure and also the challenges that we are facing. So, if you look at the RVOT anomalies, the majority of them, 77% of these anomalies, are constituted by tetralogy of Fallot, wherein a surgical correction has been done and you're left with severe pulmonary regurgitation, which needs to be addressed at a later date. Then, of course, approximately 23% of them are constituted by pulmonary atresia, truncus arteriosus, and all this, where all of them, or 90% of them, more than 90% of them, will require an RV to be a conduit. There have been attempts nowadays to do surgery without conduits, but the typical practice is to place a conduit from the right ventricle or the subpulmonary ventricle to the pulmonary artery. Now, the clinical indications in the context of RV pressure overload and pulmonary stenosis has all been highlighted. So typically there are two groups of patients, one who have pressure overload and the second group of patients are the ones who have volume overload. So there are all indications as to when to do it. uh, if you have severe right ventricular dilatation, an RV volume of more than 150 ml per meter square, if you have severe stenosis, where the RV systolic pressure is more than 65% of the systemic pressure, or more than 75% in asymptomatic patients, it is time to intervene. So these
So
indications.
among critically ill COVID-19 patients requiring ICU support.
So what is the management strategies in all these patients? Either you do a surgical replacement of the conduit with a bioprosthesis, homograph, xenograph, and nowadays some groups are also practicing metallic valve implants in the pulmonary valve. The second one, which is now more exciting and which is being practiced more and more, especially in the Western population, is the transcatheter pulmonary valve. It went through a staged procedure. Initially, balloon angioplasty was the only thing that was available, but it is usually not effective and can be dangerous, especially if the conduit is calcified, it can rupture. Then there was a certain group which used bare metal stent in order to relieve the stenosis, but then you were left with free pulmonary regurgitation. You might relieve the stenosis, but then you will be left with severe pulmonary regurgitation. And then, of course, the transcatheter pulmonary valve replacement. Our own experience is limited to now 9 cases. We started this program last year and they were enrolled for transcatheter replacement. 8 of them were successful. The mean age and weight was 15 years and 69 kilos respectively. Mean procedure time about 140 minutes. 3 patients had degenerated bioprosthetic valves, which has already been implanted in a group of patients with tetralogy of Fallot with pulmonary regurgitation. And 5 patients had dysfunctional RV to PA conduit. The unsuccessful case had, of course, a dysfunctional RV to PA conduit. So let's take one example after the other. This is an 18-year-old boy who had a diagnosis of tetralogy of Fallot, had a post-PVR done in 2010 with the Carpentier-Edwards valve, and you can see the severe stenosis which has developed in this particular valve. We do all these measurements with a combination of MRI and CT. This is a typically valve-in-valve procedure, relatively easy, and you can see that the implant has been done inside the valve, inside the bioprosthetic valve, and we have eliminated the obstruction and of course the pulmonary regurgitation also. So this is a fairly simple procedure, provided of course one sticks to detail. This is a Melody transcatheter valve which has been implanted into the bioprosthetic valve. The second patient is a 16-year-old boy a similar history, underwent a pulmonary valve implantation, a 23 millimeter perimount valve, and has now developed severe RV obstruction and right ventricular dysfunction. You can see the valve here at this particular point, and of course the severe pulmonary regurgitation and the obstruction on the Doppler finding. A very similar thing we had to do. The only thing, we had to clarify the position of the coronary arteries. I'll talk about it later. So a series of testing has been done in order to clarify that there is no coronary compression, which was suspected could occur on the CT. Once that was ruled out, then of course the procedure was relatively simple. Again, a valve in valve procedure. You can see that the stent which contains the valve has been implanted into the pre-existing valve. The obstruction has been relieved and the pulmonary regurgitation has been relieved. Now, this particular case are the ones which we encounter more commonly. They are patients who have already had an RV to P, a conduit. Typically, these are Contegra valves which has been implanted about a decade ago and has now developed degeneration of the conduit and with severe obstruction and sometimes with severe pulmonary regurgitation also. You can see that the right ventricle is dysfunctional, and you can see the severe calcification that has developed inside the conduit. And herein lies the challenge as to how to relieve this obstruction and also to relieve the uh, regurgitation. We have to take into resort a lot of investigative modalities. The first one is, of course, the CT. We have to look at the extent of calcification as to how to relieve this obstruction and also to see that the coronary arteries are not compressed in the process. So after the CT, they undergo a series of investigation. First, we do a balloon occlusion with a compliant balloon, look at the obstruction, see that there is no coronary compression, and then we move on to, and if you look at this, there was a suspicion of right-sided coronary artery compression. The left was relatively free, but the suspicion was on the right side. If you look at this right-sided coronary artery, it lies right along the pathway of the calcified conduit. So herein lies the challenge to implant the pulmonary valve without causing compression of the coronary arteries. So a continuous injection into the coronary arteries would be necessary. Once we are sure, then of course we dilate that conduit calcified area with a high pressure balloon. This is a dangerous step because sometimes these conduits can rupture with the extent of calcification. So it has to be a very, very slow process. Then we implant a conduit, not a conduit, I'm sorry, we call it pre-stenting with the CP stents. And you can see that the stent has now relieved the obstruction, but it has left with severe pulmonary regurgitation. And again, you notice that each time we are doing the coronary artery testing in order to confirm that there is no compression. And then after we are sure about it, we go ahead and implant the melody valve into the stent. The reason for doing this, I'll come talk to you soon about it. And then after the stent implantation, we again do the coronaries to be very sure that there is no compression. So this is a tedious process. At each step, we must be ready to back out, especially with these calcified conduit. And finally, after the valve is implanted, we do a final check angio. If you look at the coronary arteries, especially the right coronary artery, fortunately, nothing has happened. There is no compression of the arteries. And this is the final angiogram, no stenosis and no regurgitation. There are issues with the melody valve. Initial attempts were at deployment without stenting. A valve in valve can still be done without pre-stenting. Otherwise, all these patients who are going to have a melody valve will have to have a pre-stenting of the conduit in order to prevent fracture of the stent housing the valve. Because they notice that without pre-stenting, if you implant a melody valve, there is a high incidence of stent fracture and degeneration. Pre-stenting has to be done with a covered stent to create a wide open passage for easy deployment of the melody valve. And also, the covered stent protects the friable and calcified conduit from the consequences of rupture, which is always at the back of our mind. Here was one of the failed cases. There was nothing wrong with the coronary arteries, but there was extensive calcification of the conduit, and we could not take the sheath across the calcified area, and we had to back out. This was one of the failed cases of a calcified conduit. Nothing wrong with the coronaries, but there was such extensive calcification that we just couldn't take the sheath across and couldn't implant the stent. Contraindications, transcatheter pulmonary valve replacement. There is an absolute contraindication. If at any point of time during the testing phase you demonstrate coronary compression, then it is an absolute contraindication. Relative contraindication, we have to use a child who is more than 20 kilos typically. The conduit size which was initially implanted has to be more than, it cannot be less than 14. And then of course sepsis, groin excess, etc. Now, this is a small group of patients as we discussed. Only 22% of the normal population will have a conduit. Majority of them, 77%, will have no conduit. So severe pulmonary regurgitation following tetralogy of Fallot remain or constitute the majority of dysfunctional right ventricular outflow tract. They all require close long-term follow-up, as the majority will currently have surgery in infancy. Typically, the first 10 to 15 years are an asymptomatic period in life, but like any other regurgitant lesion, symptoms appear late in this subgroup, so constant vigil is necessary. Echo, MRI, ECG for volumes and functions of the right ventricle and left ventricle. A different strategy is necessary in these group of patients. The typical anatomy of a native RVOT dysfunction is severe pulmonary regurgitation, no right ventricular outflow tract or minimal right ventricular outflow tract stenosis. Many will have stents in the LPA or RPA and a hugely dilated RVOT and pulmonary annulus, and therein lies the challenge of inserting a valve by the transcatheter technique. So we require methods or techniques to narrow the right ventricular outflow tract, so to speak. Either we can do it with multiple pre-stenting to create a bed for inserting the balloon expandable valve. There are now stents available which are not available in the country. It's called the Altera Adaptive. I'll show you some pictures. We have not done any of these. Or we can also pre-stent it by the CP stent or an Andra stent. The second strategy is to insert a self-expanding stent with the valve, the Harmony valve and the Venus valve. Now it is with the availability of the Sapiens XT and Sapiens 3 valve, which you must be familiar with much more than us. In about 50% of cases, no pre-stenting is being done no pre-stenting is being done, and this is the latest data that is available. So these are some self-expanding valves. The Venus valve, which is manufactured in China, and you can see that the measurements are being done here in various positions. You also see the severely dilated right ventricular outflow tract. So these are self-expanding valves. There are limits to its implant. Certain measurements cannot be exceeded even if you have to implant these valve. This is the first valve which was developed, the Harmony valve, which was developed by Medtronic. It has undergone various stages of evolution, and today we have this modified TPV 25. 25 means 25 millimeter size valve, which is being used, and the data is still yet to come out on its use. So a lot of hard work goes into determining whether a patient will be suitable. We have these 3D rendering of the right ventricular outflow tract in systole and diastole. Then there is this virtual implant which is being done in order to check that it will be suitable for this particular right ventricular outflow tract. And then only they go ahead and implant it. This is the latest development which has occurred now. This is a self-expanding Altera pre-stent with the partially covered stent in a nitinol frame. They go and deploy it in the right ventricular outflow tract, and then over this you implant the sapiens valve in order to get rid of the pulmonary regurgitation. And then, of course, most of you are familiar with the Sapiens XT and Sapiens 3 valve. This is one of the exciting things that have been developed in for aortic valve, but now is being gradually also being used for the dysfunctional RVOT. So, ladies and gentlemen, PPI has evolved into an attractive alternative to surgery in order in children, older children, and adults with dysfunctional ventricular to pulmonary artery conduits. Indications of implantation are still evolving. A more aggressive approach will be required over the future if you have to cater to the large subset of patients who actually require it, that is the native right ventricular outflow tract. The crux to a success is, of course, the case selection, especially in those who have a dysfunctional RVOT, native dysfunctional RVOT. As I said, the majority of patients have dilated right ventricular outflow tract with severe pulmonary regurgitation, not suitable for a melody valve. We don't have access to the venous valve. The ultra adaptive stent is yet not available, although the Sapiens valve is available. Cost is a very important major constraint. There is actually no comparison for a patient to have a repeat surgery vis-a-vis to put these valves inside. The cost is almost 5-6 times more than the cost of a surgical thing. All these factors combined will always limit the number of cases that we do in a country like India. Thank you very much. Finally, the AHA statement in 2011 stated that it is reasonable to consider pulmonary valve replacement in patients with right ventricle to pulmonary artery conduit with associated moderate to severe stenosis or regurgitation, provided the patient meets the inclusion-exclusion criteria of the available valve. It's a class 2A indication with level of evidence B. Thank you for your kind attention.
Thank you, Radha sir, for your excellent talk on this topic. As usual, as we are running short of time, is there any questions from audience?
Yes, Dr. Prabhat, Dr. Nishant here. Radha sir, very warm regards from our organizing team, and Dr. Nishant here, sir. I think we can have some questions because we have got excellent, all the three topics were excellent, and I can see Chatterjee sir, do you have some question or comment, Chatterjee sir? Chatterjee sir probably have left. Sir, Dr. Radhakrishnan sir, you told that you pre-stent the conduits before putting the proper stent.
Yes.
Can you, sir, elaborate something, why that is necessary?
Initially, they tried to implant the melody valve after balloon dilatation on the conduit. But over a period of time, they noticed high incidence of stress fracture of the melody valve. I mean, the stent which has the valve, there was a lot of fracture of the stent, and also the stent became dysfunctional. So they thought that they should provide a scaffolding onto the conduit in order to implant the melody valve. And after they started this practice, the incidence of fracture of the melody valve became negligible. So when you have a conduit, you always have to pre-stent it. One is, these are all covered stent, remember. The covered stent helps to protect the calcified conduit even if it ruptures or leaks. The covered stent will protect it. And then, of course, after that, you implant the melody valve inside the stent in order to prevent fracture of the stent.
Thank you, sir. Chatterjee sir, do you have something to a comment on sir topic or unmute? Unmute. अनम्यूट सर, अनम्यूट कर लीजिए।
हेलो,
अनम्यूट कर दो।
यहाँ से नहीं हो रहा सर, सर खुद करेंगे।
चटर्जी सर, अनम्यूट करना होगा आपको।
Thank you, Dr. Radha. Thanks for presenting your topic on pulmonary valve replacement, transcatheter. This is an upcoming topic. I don't have any personal patient to comment upon. You are doing it. That's a good. I think most of the patients of tricuspid valve that adults say after 20 years or 25 years, I mean, when they become 20 years or 25 years, most of them do develop pulmonary regurgitation and severe pulmonary regurgitation. And till now, we did not have anything proper to do it. But pulmonary valve, transcatheter pulmonary valve implantation will definitely do a very positive role to the patient. Thank you, Dr. Radha.
thank you, sir.
Thank you.
Nice to see you after a long time.
Sir.
This is Corona time. So
I think we had a wonderful session because we are running.